Time is tissue. In acute toxicology, misidentifying the clinical signature is literally fatal. We're bypassing all the pleasantries today and jumping straight into the clinical material. This explainer is a strict peer-to-peer clinical simulation, and it's calibrated specifically for elite board preparation. If your target is that perfect 280-plus score, you need absolute mastery of the intricate mechanisms, the discrete management steps, and the ability to instantly recognize high-yield diagnostic traps. So we're locking in on heavy metal toxicity. It's a prime testing area where subtle clinical variance determines whether your patient lives or dies. Let's get to work.
Keep this core clinical maxim front and center. Imagine you're on ICU ward rounds. A patient presents in extremis, and the clock is actively ticking. You absolutely do not have the luxury of endless diagnostic fishing, right? You have to identify that precise toxicological signature immediately. Our goal today is to map those exact signatures so deeply into your diagnostic framework that recognizing them becomes an automatic reflex. We are going to strictly train your defensive test-taking skills so you don't fall into cognitive anchoring when test writers hit you with aggressive distractors.
Module 1. The erythrocyte destruction, focusing on lead.
Look really closely at this peripheral blood smear. Lead causes a massive systemic heme blockade. How? It strictly inhibits ferroculitase and ALA dehydrase. And the absolute microscopic signature of this destruction is right here. Those distinct blue granules scattered throughout the red blood cells. That's basophilic stippling. When you see a microcytic hypochromic anemia paired with basophilic stippling in a patient with the right risk factors, think occupational exposure in battery manufacturing, plumbing, or maybe auto repair, lead toxicity has to immediately jump to the absolute top of your differential. Oh, and for kids, don't forget to look for those classic lead lines on the gingiva and the metatheses of long bones.
Now, beyond the blood smear, lead toxicity presents with a highly specific systemic clinical triad. First up, severe intermittent abdominal pain. We call this lead colic. Second, peripheral neuropathy, which classically manifests as a motor weakness. You'll see this tested as wrist drop or foot drop. And third, as we just saw, that microcytic hypochromic anemia. In pediatric cases, they might also test you on acute encephalopathy or hyperirritability. Recognizing this exact triad is your first crucial step in the clinical simulation.
So the crucial point here is breaking down the discrete management steps, and these are based strictly on the patient's blood lead levels and clinical severity. For mild to moderate toxicity, which is defined as blood lead levels between 45 and 69 micrograms per deciliter, the mandate is oral succimer. Just remember, it sucks to have mild lead poisoning. But listen, the moment those levels cross 70, or if your patient shows literally any signs of severe encephalopathy, the protocol aggressively shifts. You are strictly mandated to initiate intravenous therapy with demercaprol, followed by calcium disodium EDTA. Memorize this exact distinction because it is highly tested.
Module 2. The garlic breath and the QTC trap. Let's talk about arsenic.
I really want to anchor your diagnostic eye on this number. A dangerously prolonged QTC interval of 520 milliseconds on an ECG. This is a classic high-stakes diagnostic trap. When a patient presents acutely ill and the monitor shows a massive QTC prolongation, your immediate impulse is going to be to treat this as a primary arrhythmia, right? You want to reach for antiarrhythmic drugs. Do not take the bait. In the context of our next clinical markers, this ECG finding is actually the deadly cardiac signature of arsenic poisoning.
And this perfectly illustrates the rapid sequence of arsenic's multi-system attack. It all begins with environmental exposure, usually a pesticide plant or maybe contaminated rural well water. Arsenic is a brutal mitochondrial poison. It strictly inhibits pyruvate dehydrogenase and replaces phosphate in ATP synthesis. This immediately progresses to severe GI distress. We're talking acute vomiting and massive watery rice water diarrhea. Then you get the definitive clinical marker, a distinct garlic odor right on the patient's breath. Finally, that life-threatening cardiac phase emerges with the prolonged QTC interval, putting your patient at imminent risk for torsades de pointes. Recognizing this exact sequence is absolutely mandatory. Module 3. The clinical variance matrix.
Now, before we execute the direct comparison you see here, we have to acknowledge the third pillar of our heavy metal triad, and that's mercury. Mercury strictly targets the central nervous system and the kidneys. It presents with a distinct neuropsychiatric tremor, severe irritability, known as erythism, and acardenia, which is a painful peeling of pink skin on the hands and feet in children. Now, deploy this rapid-fire heuristic to train your defensive test-taking. If a prompt gives you neuropathy with abdominal pain, look for the variants. Lead will feature basophilic stippling, motor-dominant neuropathy like wrist drop, and constipation-type colic. Arsenic, on the other hand, gives you QTC prolongation, that unmistakable garlic breath, and massive watery diarrhea instead of constipation. And if the prompt presents a tremor with severe irritability and peeling pink skin, you bypass both lead and arsenic, and you select mercury. Lock this matrix into your memory to completely prevent diagnostic anchoring.
The master case, testing the nuance.
All right, we've reached the climax of this explainer. Read this patient profile blueprint carefully. A pesticide plant worker presents with massive watery diarrhea, severe abdominal cramps, and a garlic odor on his breath. An ECG reveals a QTC of 520 milliseconds. What is the immediate chelation mandate? Notice the diagnostic trap embedded right there in the prompt, that QTC of 520. The test writer is aggressively tempting you to select an antiarrhythmic or to manage this as severe infectious diarrhea. We're going to bypass that distractor together. You have to identify the underlying arsenic toxicity from the pesticide exposure, the diarrhea and the garlic breath, and then determine the exact antidote.
Let's execute an exhaustive, choice-by-choice breakdown exactly like you'll face under actual exam conditions. Option A, dimercaprol. This is the correct answer. It's the absolute first-line chelation mandate for acute arsenic toxicity. Option B, succimer, is a distractor targeting lead poisoning. While it is a heavy metal chelator, it is entirely incorrect for the garlic breath and QTC prolongation signature we see with arsenic. Option C, deferoxamine, is strictly the antidote for iron poisoning. That would present with hematemesis and radiopaque tablets on an X-ray, definitely not garlic breath. Option D, sodium bicarbonate, is a highly competitive distractor because it treats cardiac manifestations, specifically the widening of the QRS complex in TCA overdose, and it's used for salicylate toxicity. But it does absolutely nothing for arsenic-induced QTC prolongation. Finally, option E, famotidine. This is the antidote for ethylene glycol or antifreeze toxicity, which you'd identify by acute kidney injury and calcium oxalate crystals.
Master this matrix and you eliminate the distractors instantly. Diagnostic discipline saves lives. Identify the toxin. Don't just treat the ECG. Keep that absolute principle in mind as you face these high-stakes scenarios. When you see an ECG abnormality, you must always ask yourself if it's the primary problem or just a secondary signature of a deeper toxicological blockade. Master the clinical triad, know your strict chelation mandates, and never fall for the distractor. So, what's your next move? Are you ready to apply this exact level of precision to your next clinical simulation?